When I go to speak to places, it's often because the people on the ground that are given an institution find themselves in the situation where they've bought a product, they're trying to use it, and the doctors are balking, and they're not happy. And usually, when you explain where our evidence comes from, you explain what our content is to be used for. Because sometimes they've heard a different story. They've heard it's not a goal length of stay. They say it's MCG gives you 2 days, which is not at all what the goal length of stay is about. So usually when they see the content and they hear what we're about, they're like, oh, okay. I still not like having my decisions re-examined like that. But I see that this is a better tool to use than just, the CFO saying to the hospitalist group, you admit too many patients, or you admit too many cardiac patients. This allows you to get a little bit more specific and identify where the problems are, but also identify where it's not a big problem, and let's not focus on that and ruffle any feathers there. Absolutely, the adage is it's very hard to change physician behavior in general. It's even harder to do it if the person talking to them is not another physician. It shouldn't be that way. It is. So meaning when the nurse case managers or the CFO, whoever it is talking about clinical utilization, often they're not very receptive. Of course, there are exceptions. This type of information, first of all, it facilitates a doctor to doctor. So the VPMA of a hospital or the physician advisor who's in charge of helping reduce the COPD admissions is armed with some clinical doctor to doctor information to speak about that gets past the you're wrong, you're making a mistake, somehow you're bad, to look, lots of people have lots of diagnoses that they're sort of out of whack. And guidelines can help get you back on track. If there's something in the guidelines that strikes you as just ridiculous and it doesn't make any sense, certainly bring it up. And we've made changes based on either misunderstandings or missing pieces. It's not very common, but gee, you should add this piece too to help me decide what level of care. So I think it's a tough lift anyway to change physician behaviors. You at least need to use our content like ours and have data that means something. It's not just cherry-picked data. You're measuring the right doctors. You're talking to Dr. Smith, and it's his patients you're talking about, not somebody else's, because that's not going to help either. And the other piece is align the incentives as best you can. Financially, in some regard, don't make it in the ED physician's financial interest to admit more people and then want them to admit less people, or admissions by hospitalists, or length of stay, whatever it is. Try to align the incentives as best you can. And some of it is also logistics. There are situations where admitting a patient from the ED is easier, paperwork-wise, bureaucratically, than discharging them and setting up the home health service and the follow-up appointments. So the easier you can make an alternative decision look like, it just becomes an easier decision. It'll also be easier for people to not admit people and do something else.